want to thank everyone for inviting me here on behalf of the Society of Cardiovascular Angiography Intervention in Harvard University Medical School. I'm going to talk about a common problem, and this is a problem which actually I have more questions than I have answers. As you know, severe aortic stenosis really affects people of older age, and coronary artery disease also is an age-related disease. So it should be of no surprise to anyone that coronary artery disease is common in patients with aortic stenosis. About half the patients undergoing TAVR have coronary artery disease, so this is a common entity. And most of the clinical practice guidelines recommend coronary angiography or some sort of ischemic evaluation prior to any kind of surgical or transcatheter aortic valve replacement. This is particularly important in patient subsets, such as patients who have a history of coronary disease or at least one cardiovascular risk factor, suspected myocardial ischemia, LV dysfunction, older age, or postmenopausal women. So, but basically, I think most patients undergoing TAVR in today's day and age get some sort of an ischemic evaluation, and usually that's going to be coronary angiography. Coronary angiography is the gold standard and remains the standard for evaluation of coronary artery disease in patients being considered for TAVR. It has lots of advantages, and you can see them all here. It's unaffected by the calcium, although we just heard talks showing that angiography really doesn't show calcium well. Most practice guidelines are based on angiographic extent of disease. And if you are doing invasive coronary angiography, you can do immediate invasive lesion assessment, and you can have the potential to proceed directly to PCI. Usually, coronary angiography is done preceding TAVR at a different setting, so it's done ahead of time. Although it can be, in some patients, done at the same time as TAVR, particularly in low-risk patients. There are disadvantages to invasive coronary angiography. You should all know what they are by now: vascular complications, contrast nephropathy, and obviously the delay of treatment. Multi-slice CT is a newer option for evaluating patients for ischemic heart disease. The nice thing is it's non-invasive, but again, it has artifact that can be seen in patients with a lot of calcium. You can see the pooled sensitivity, specificity, positive predictive value, and negative predictive values for CT. And although it's very sensitive, its specificity and positive predictive value are not over 90%, they're less. So most students of the field feel that multi-slice CT is not really the standard for ischemic evaluations in patients being considered for TAVR, that invasive coronary angiography really is the gold standard. Now, invasive coronary physiology assessment at the time of coronary angiography is something that can be done. Although there's a lot of conflicting data out there, severe aortic stenosis does affect IFR and FFR measurements and tends to underestimate them. But however, the guidelines still recommend using the same benchmarks of an FFR less than 0.8 and a IFR less than 0.89 as the cutoffs for ischemia. So most patients undergoing angiography for being TAVR are not having coronary artery disease-related symptoms. Most are asymptomatic. So which patients should be treated then? This is a big question. It's a big question mark. There's a lack of randomized controlled clinical trial data. There's a lack of consensus. And then more than that, the timing of PCI, if you're going to do it in these patients. Should it be done ahead of time, before their TAVR, after their TAVR, or at the same time as their TAVR? These are issues that remain to be resolved. And then, of course, patient selection. Most of the patients undergoing angiography for TAVR are asymptomatic. So which of those patients should you treat? If they're symptomatic and having angina or myocardial infarction, acute coronary syndrome, or acute heart failure, those patients should be treated, but when? And then lesion location and severity is the important question. And then the choice of transcatheter heart valve. The choice of transcatheter heart valve heavily influences your ability to treat coronary artery disease percutaneously, and I'm going to show you that in a second. This is the clinical data as it exists today. There's a meta-analysis of 11 studies enrolling over 5,000 patients with documented asymptomatic coronary artery disease and comparing PCI followed by TAVR to TAVR alone. And in this meta-analysis, they found no difference in outcomes in terms of 30-day mortality, myocardial infarction, renal failure, and 1-year mortality in patients treated with PCI versus not being treated with PCI in asymptomatic patients. And there was one randomized trial, the activation trial, which randomized patients comparing PCI before TAVR versus TAVR alone in patients with documented asymptomatic coronary disease. They had to have at least one lesion, 235 patients. The primary efficacy standpoint was all-cause mortality or rehospitalization at 1 year. And there was no difference in outcomes between PCI versus no PCI prior to TAVR. So most of the data out there shows really no benefit to PCI in patients with asymptomatic coronary disease, incidentally noted during a pre-TAVR evaluation. There is a randomized trial which is ongoing, which we've been part of, called the Complete TAVR trial. In this trial, patients with coronary disease are randomized to undergo TAVR versus PCI. Now, in this particular study, TAVR is done first and the PCI will be done second. So patients undergo coronary angiography. They have at least one lesion of 70% in a major epicardial coronary artery. Then they undergo TAVR. And then they are randomized to follow-up PCI versus no PCI in medical management. This trial is ongoing, and the results should be available in the next couple years. But until then, we're just not going to know. The European guidelines for myocardial revascularization, and I've circled the important one, that PCI in patients undergoing TAVR or surgical valve replacement should be performed in patients with a primary indication to undergo TAVR and a coronary artery lesion greater than 70% in a major epicardial coronary artery. Now, I have to tell you that this is the guideline, but I don't necessarily do this, not consistently. This is a two-way recommendation with poor level of evidence, C. So this is just a guideline, and I have to tell you in my practice, I sometimes don't do this in very elderly patients. If you're going to do PCI, then what is the timing of that PCI? Should it be done before the TAVR, after the TAVR, or combined? There are advantages and disadvantages to each. The advantages of doing it ahead of time is you don't have a valve in the way that can interfere with your cannulation of the coronary arteries. There's a lower risk of ischemia-induced hemodynamic instability when you do your TAVR. And then there's less contrast. Of course, when you use physiologic measurements, as I said, they can be affected by severe AS, and then you have a higher risk of hemodynamic instability due to aortic stenosis. Doing PCI after TAVR has its own problems. Although physiologic analysis is more accurate, there's a lower risk of hemodynamic instability during complex PCI because of the lack of the aortic stenosis. But there's a potential for more instability because of deferring the PCI after TAVR. That when you're doing your TAVR procedure, you could have acute ischemic problems. So doing PCI after TAVR has its own issue. It's more challenging and potentially compromised coronary access due to the transcatheter heart valve, less stability and support of your equipment, and potential transcatheter heart valve dislodgement, although I've never really seen that. And then combining PCI and TAVR together, I don't think anyone really does this. You could do it in really low-risk patients, but the length of the procedure, the additional contrast, in my mind, makes this a non-starter. So what are the other important issues? The issues of transcatheter heart valve design. Well, the stent frame height, the higher the frame, the superannular location, the skirt height, open cell versus closed cell designs, transcatheter leaflet height, commissural alignment, all affect your ability to re-access coronary arteries after transcatheter valve implantation. This is also affected by the anatomic factors such as sinuses of Valsalva, the height and width of the sinotubular junction, coronary heights, and length of the leaflets. These are the main valves that are out there on the market right now. You can see that the balloon expandable valves on the left, the Sapien 3 has the smallest frame and the smallest height, and you can see in the bottom figure that it gives you the freest access to the epicardial coronary arteries after implantation. All the other self-expanding systems require either to go through the cells or behind the cells, and it makes it far more difficult. And then the final concept of the importance of commissural alignment. When you're putting transcatheter heart valve in, it's becoming more and more important to ensure commissural alignment so you don't have the post of the transcatheter heart valve sitting right over the coronary ostium. So in conclusion, most patients with asymptomatic incidental coronary disease do not really need to be treated. Asymptomatic patients with high-grade proximal disease of a major epicardial artery should be considered for treatment in accordance with published guidelines. The timing of PCI is unclear and should be guided by clinical presentation. Patients with acute coronary syndrome should, of course, be treated ahead of time. Performing PCI in patients with severe AS can lead to hemodynamic instability, and a consideration should be given to palliative balloon aortic valvuloplasty or mechanical circulatory support in these types of patients. The choice of transcatheter heart valve should also be taken into consideration. So if you're going to be reaccessing coronary arteries and a patient has extensive coronary disease, I really advise you to use a balloon expandable valve with a short frame that gives you very easy follow-up access to the coronary arteries. The Medtronic valve can be very difficult. And then commissural alignment for transcatheter heart valves is a newer concept which is going to gain increasing traction and ultimately will be responsible for ensuring commissural alignment on these patients. So with that, I want to thank you for your attention and for this important topic. Thank you.